Welcome to this clinical masterclass. I am your presenter, Assistant Professor Dr. Farhad Mustafa Musa Atrushi, MD. And today, we are evaluating the mechanics of blood flow control in the operating room. Our primary objective is to define a precise protocol for achieving total surgical hemostasis while avoiding the application of unnecessary pneumatic pressure to the patient's limb. Relying on standardized static pressure settings often leads to incomplete occlusion or avoidable soft tissue and nerve damage. Modern surgical practice necessitates personalized hemodynamic adjustments. To achieve this level of precision, we rely on the foundational clinical protocol established by Reed and colleagues. The Reed et al. Protocol requires the clinician to calculate the specific physical force needed to obliterate arterial flow for the exact patient on the table. Precise tourniquet application depends on an individualized physiological calculation that accounts for the patient's current hemodynamic state. Step 1 of the protocol involves establishing the patient's baseline hemodynamic requirement. We begin with an uninflated pneumatic tourniquet placed securely on the target extremity, surrounding an artery with active pulsatile blood flow. We then place a Doppler stethoscope distal to the pneumatic cuff. This allows us to monitor the active peripheral pulse via both an auditory signal and a visual waveform. As we slowly inflate the pneumatic tourniquet, the increasing inward pressure begins to compress the target artery. During this compression, we look for the exact moment the auditory pulse signal and its corresponding waveform completely flatlines. This state of arterial obliteration is defined as the limb occlusion pressure, or LOP. The LOP represents the absolute minimum pressure required to stop blood flow at this specific moment in time. While the LOP is our critical starting point, it represents a fragile equilibrium that is insufficient to maintain occlusion for the full duration of a surgical procedure. Setting the tourniquet exactly at the measured LOP is dangerous during an active surgery because it lacks the capacity to handle physiological fluctuations. This necessity leads us to step 2 of the Reed protocol, applying a safety margin. To calculate the final pressure, the clinician adds a margin of 50 to 75 millimeters of mercury to the baseline LOP. This addition accounts for collateral circulation. Even when the main artery is compressed, smaller secondary vessels can bypass the occlusion. The extra pressure ensures these deeper alternative vascular pathways are adequately compressed, preventing blood loss into the surgical field. The safety margin also explicitly accounts for intraoperative blood pressure changes. Normal surgical stress causes systemic systolic blood pressure spikes. These spikes would overcome a tourniquet set only to the bare limb occlusion pressure. This 50 to 75 millimeter addition provides a calculated evidence-based buffer designed to counter physiological variables and guarantee continuous hemostasis. With the calculation of LOP plus margin established, we can map this data against the expected anatomical realities of the operating room. Upper extremities and lower extremities possess different tissue masses and vessel depths, which changes the force required to safely compress them. In the upper extremity, the Reed et al. Protocol typically results in satisfactory tourniquet pressures between 135 and 255 millimeters of mercury. For the lower extremity, the heavier tissue mass requires a higher functional range, usually between 175 and 305 millimeters of mercury. Clinicians use these established ranges to verify that their individualized Doppler-derived calculations are physiologically sound. Correctly applying the LOP algorithm reliably produces measurements within these safe, predictable anatomical bounds. Let us review the complete algorithm for the surgical team. Step 1. Pinpoint the exact limb occlusion pressure using the Doppler stethoscope distal to the cuff. Step 2. Add the 50 to 75 millimeter of mercury margin to account for collaterals and pressure spikes. Finally, verify the total against the expected anatomical ranges shown here. Using this specific arithmetic eliminates the risks associated with arbitrary pressure settings. Precision in pneumatic tourniquet application, measured, buffered, and verified, is the definitive standard for safe surgical hemostasis. This concludes our clinical lecture. Thank you for your commitment to evidence-based surgical practice. The clinical material and foundational framework for today's masterclass were provided by our esteemed colleague,